Everyone, and welcome. Thank you for joining today's webinar, Securing Support for Those Who Are High Risk for Hospital Readmissions, presented by Home Instead and hosted by the American Society on Aging. We'll begin shortly, but first, let's cover a few important notes. The certificate application for your CEs and for your certificate of attendance will be accessible immediately after today's webinar on the tab right above the presentation screen. When completing your application, please be sure to select a certificate type labeled as Credit Reporting Organization and enter your license number labeled as Membership Number. If you don't make a selection, no certificate will be generated because it won't know which one is the right one for you. The on-demand recording for today's webinar will be available within 48 hours right back here in your classroom. And there will be checkpoints during the webinar to ensure active participation, so please be prepared to respond to those as they pop up on your screen. For more information, please review the FAQs document. It's linked in the announcements tab right below this window. It's also available on our webinars page and in your emails if you need to reference it again. Presentation slides are in the materials tab and will not be included in follow-up emails, but feel free to download them now, or you can access them in your classroom at a later time. Ensure that you are logged into the webinar with the email address you registered with, or we have no way of tracking your attendance. Your time is logged, and you must view the entire webinar and complete the checkpoints to apply for a certificate. You have 60 days from today to complete your application. For any technical issues, please use the helpline available under the Help tab at the top of your screen. And for any questions about today's presentation, please use the Q&A tab right below this window. We'll do our best to address those in the last few minutes of the webinar. And now I would like to introduce today's presenter, Lakeland Eichenberger, a gerontologist and caregiving advocate at Home Instead. With a doctorate from the University of Nebraska, Lakeland is a renowned speaker and expert in elder care. Lakeland, we're so excited to have you here today.
Thank you so much, Victoria. Hi, everyone. It's great to be with you today. Thank you so much for joining us. Today, we're talking about an important topic, securing support for those who are at high risk for hospital readmissions. And we know hospital readmissions has been kind of a buzzword, a hot button topic for the last few years. And I think we continue to talk about it because it continues to be relevant in the aging population. And so, again, I'm really glad you're joining me to talk more about this. And there are, some risk factors that can contribute to hospital readmissions. And for older adults, there are many risk factors. And so, today, through the webinar, we're going to be exploring strategies for securing support systems, especially for individuals with specific types of risk factors. So we will dive right into it here. I'm going to get to our objective slide. So this is what we plan to cover today. We're going to talk about the prevalence of readmissions among older adults, and we're going to key in on 5 common risk factors that can increase a person's risk for readmissions. As I mentioned, there are many risk factors, but there are 5 that have kind of stood out to me over time. So I wanted to kind of call them out in today's webinar. But again, I want to acknowledge there's far more than just 5. But I think if we can learn about these 5, acknowledge them in the patients or clients that we work with, hopefully that will heighten our awareness as they return home from the hospital to best support them to reduce the chance that they will be readmitted to the hospital. And that's really one of the next objectives, making sure they have the right support at home to help reduce that risk of readmission. And then we'll wrap up, of course, with resources. I always love to share resources at the end of each webinar. So let's talk about older adults and specifically healthcare considerations for this demographics. There's a number of, there's a number of considerations that, again, could put a person at risk for readmissions or challenges in complying with a hospital discharge plan when they're returning home from a hospital setting or rehab setting. First, we also do want to acknowledge the reason it's so important for this population to talk about readmissions is because older adults are the largest consumers of healthcare in the US. People age 55 and older account for over half of the total health spending. And so for that reason, often older adults are transitioning home from a hospital or rehab. It's a common thing that is occurring every single day. But we do know that there can be changes or limits in a person's physical and cognitive levels of functioning that could impact their transition home from the hospital. So we need to have those supports secured in place to help them as they navigate that discharge plan. We also have to be mindful of a recent history of frequent healthcare visits or interactions. Some older adults are considered kind of quote unquote frequent flyers who return to the hospital or to the ER or to the clinic regularly. And if we're able to kind of dig deeper into their situation, hopefully we can uncover some of the risk factors perhaps for that individual that would contribute to them coming back time and time again. We also know that multiple medications often are common among older adults. And we also know comorbidities can be common. So if you have multiple chronic conditions that you are faced with, and then you're given a discharge plan on top of an already complex medical situation, that can be overwhelming. Or if you have a lot of changes in the medications after returning home from a hospital stay, that can lead to some medication mismanagement, which we're going to talk more about. We know that falls are more common among the older population, and we know that if a fall occurs once, it's more likely to happen again, so we want to be mindful of that. We also know that transportation can impact an older adult's ability to get to healthcare appointments, to receive the necessary medical care that they need. We also see scheduled surgeries amongst this population. Not all hospitalizations are due to an accident or a fall or a health kind of crisis. Some of them are planned for. If you kind of follow the national poll of healthy aging, that study identified 5 common elective surgeries among older adults. And the most common was joint surgery. So things like hip and knee replacements. Eye surgery was also more common, second most common, then abdominal surgery, cosmetic surgery, and then 5th was foot or leg surgery. So in my experience, I do see a lot of planned surgeries for joint replacement. And I also encounter a lot of eye surgery procedures for older adults. And so we know that often when they're returning home from these scheduled surgeries, they're going to need some additional support. But the great thing is when they are planned, we can hopefully then plan ahead for that return home. But so often there's no opportunity to plan because an older adult ends up in the hospital due to a crisis situation. And we know that the support at home for every older adult varies. Some might have family, some may not because of proximity. Their family might live far away, or maybe they're working during the day, and so they don't have that support system. And so we need to look at support beyond family and what are the options. We're going to talk about that more later. And then for those older adults that live alone, that of course can be a concern, especially if they're coming home with limited mobility. They might not be able to, again, adhere to that discharge plan because they don't have that support. And finally, there's no secret here. We know that healthcare, it can be a tricky system to navigate. And so often an older adult, they will need help and support to navigate the healthcare system, to get to those follow-up appointments, to see a specialist and kind of keep all things straight. So there's a lot of considerations. We're going to, again, dive deeper into some of these in just a bit. But we want to talk about and review the prevalence of readmissions to just really kind of help us understand, again, this might be a review for some of you, but we want to understand, why are readmissions so important? And it is a hot topic because readmissions are costly. It's actually the costliest episode to treat. And in 2018, I know that data's a little outdated at this point, but we know that in 2018, there were 3.8 million 30-day all-cause adult hospital readmissions that totaled $50 billion in readmission costs. And that's a big lump sum of money. And if we can prevent even a fraction of those hospitalizations from happening, it can be a significant cost savings. And not only that, but also an improvement on a person's quality of life to not have to go back to the hospital. And you can also see that a readmission is more costly than the average hospital stay. So, the average readmission is about $14,500. A readmission is about $16,300. So it's about 12.5% nearly higher for a readmission cost than kind of your general admission. So again, money talks in our society, unfortunately. And so when we're identifying these high costs of readmissions, there's a lot of motivation to reduce those readmissions. So some other interesting kind of readmission statistics and information. There was a study by Wang and colleagues that did a nationwide hospital admissions data statistics kind of study, and they found that nearly 1 in 8 community living older adults had a hospital readmission within 30 days of major surgery. And that's about 1.1 million older individuals. And then 1 out of 4 had a readmission within 180 days. So when we're looking at readmissions, we often talk about that 30-day readmission because with this new kind of hospital readmission reduction program, there are some kind of more stricter, stringent guidelines around that 30 days, but they're also looking beyond that. So the 180-day readmission rate is also something that is watched very closely. So not only do we want to prevent readmissions, right out the gate in that first month, but we want to keep them out of the hospital for really as long as we can. We also know that Medicare beneficiaries, those 65 and older, account for most of these readmissions. And so that's really a big driver behind the establishment of that hospital readmissions reduction program that came about in 2012. It was developed by the Centers for Medicare and Medicaid Services, and it really aimed to improve the quality of patient care and reduce the healthcare expenditures by putting fines on hospitals with higher readmission rates than really kind of the rate that they hope to see. So the goal of this, again, is to reduce those expenditures, but also improve the quality of life for the patient, which I think as a gerontologist, for me, that is really important. Going to the hospital, it's not always a fun situation. A lot of older adults want to stay out of the hospital or get out of the hospital as quickly as possible. So these programs are trying to do that. They're trying to improve the quality of life for the patient. And there's kind of these incentives that are starting to drive the reduction in readmissions. And you're starting to see hospitals really kind of get creative in the ways that they support patients after they come home from the hospital to reduce those unplanned readmissions in that 30-day window. And the early results, if you look at the beginning of the program from 2007 to 2015, that readmission rate has dropped. It went from 21.5% to 17.5%. So we are seeing that there is some success with this program. And so, again, that's why you continue to hear kind of this as a buzzword, is because readmissions are something that hospitals and health systems are continuing to want to avoid. And if we look at it from kind of the patient's point of view, again, we know they're costly, but when it goes back to that quality of life for the patient, if we can keep them out of the hospital, it can reduce the risk of infection. We know that often hospitals are uncomfortable for the patient. The beds are really uncomfortable. It's noisy. If you've ever been hospitalized, they're interrupting your sleep every couple hours to check your vitals. So again, from a comfort standpoint, if we can avoid going back to the hospital, that is usually very welcomed by an older adult or anyone really. Also, being away from the home and the living environment can have negative psychological impacts. And also, for those living with dementia or cognitive impairment, taking them out of their regular environment can increase the risk of emotional distress. And I know that there are some really unique programs that exist out there to within hospital systems to really cater more tailored approaches to care for those living with dementia and cognitive impairment. But it really, being in the hospital, takes them out of their environment and can be very stressful for the individual and their family caregiver or care partner. And then also, when you're in the hospital, you're often laying in your hospital bed, you have decreased physical activity. And so you can your mobility can decline. And so when you return home, you can be weaker than when you went into the hospital. So those are also really important things to consider. Again, it's not just reducing the cost, but it's improving the quality of life, quality of care for the patient. But we know that readmissions are complex. It's one thing to say, let's try to reduce all readmissions. It's a really great goal, but we know that not all readmissions are avoidable. Some people have to go back for scheduled treatment. Some people might be too weak when they're first admitted to have the additional treatment that they need. So they'll need to go back in for treatments that they weren't able to do the first time around. Others might be discharged for one condition or illness, and they go home and they have something new crop up. For example, one of our clients was discharged after having shoulder surgery, but was readmitted 2 weeks later due to her CHF, so congestive heart failure. So, those two were truly unrelated. And so a person might go back for something that they didn't go in originally for. So we have to also keep that in mind. But there was this interesting study or report rather that came out, was done by the Robert Wood Johnson Foundation. It was called the Revolving Door. It was a report on U.S. hospitalizations, and they took the Medicare data and analyzed it. And again, this report's a little old, but has some really interesting findings. And again, over the years, hospitals have been working to kind of address some of these challenges and concerns, and some hospitals are making great strides. But the study looked at it from both the provider perspective and the patient perspective, which I think is always interesting to kind of get that kind of two sides of the coin, if you will. So from the provider perspective, the provider kind of identified some drivers of readmissions, and it included that one, discharge decisions are complicated. There are certain reasons for hospitalizations that have higher readmission rates than others, which could impact the discharge decision and how long the patient stays in the hospital. Some providers also in this report shared that they felt pressure to discharge quickly, even if it wasn't in the patient's best interest. And think about that. I mean, if you go home before you're ready, it could put you at risk for coming back. Sometimes providers admitted there was a lack of clarity regarding, who was responsible for the older adult. Often there's many providers involved. It can cause some communication challenges. And then on the flip side of being discharged feeling pressure to be discharged too quickly, some of that might be coming from the patient's family or the patient themselves. They might really want to get home, think that they're fine, they can manage on their own, but it's really, again, maybe not in the best interest of the patient. There can be communication issues in coordinating the plan for post-discharge, and this might be communication issues between the providers, the family, the patient themselves, or the community that they're returning to, or the rehab setting that they're transitioning to. Also, believe it or not, patients are not always honest. I mean, have you ever maybe told a little fib to your doctor, oh, I'm doing better than I am, or I'm exercising more regularly than I am, or eating more healthy than I am? Providers in this report said patients are not always truthful about their home situation, and they might not be forthcoming due to things like privacy, or they might be embarrassed about their lack of resources. So that's something to keep in mind. And patients might also not have the means to meet their basic needs. And this is another issue. So they might need assistance finding resources to help meet those needs post-discharge. And I know hospitals have in place wonderful discharge coordinators and social workers that really help patients navigate some of those resources that are needed when they head home, and have a great Rolodex of resources that they can point families to. So that was the provider perspective. And then if we look at it from the patient's perspective, again, this topic is kind of an interesting thread between both. Some patients felt they were discharged too soon. They felt the timing of their discharge was motivated maybe by the hospital's financial considerations. And some wanted to, on the flip side, some wanted to go home sooner. And so that can be really, really tricky, is making sure that they're going home at the right time. Also, some did not understand their discharge instructions. If you think about it, being in the hospital, it can be tiring. So some in the reported that they felt tired, they felt afraid, they felt out of their element in the hospital. So that 15-minute kind of care instruction, the pamphlets that they were given about their illness really didn't seem enough, or they might not have remembered it all. I think that's why it's so important for families or the caregiver care partner to be involved in that care plan, discharge care plan instructions, because then they have the opportunity to ask questions or fill in the older adult on some things maybe that they didn't catch the first time. And some felt that those care instructions were too general. Maybe they lacked detail on the illness or condition. Maybe they were hoping for more specific instructions about what they should eat, what they should avoid, more details on how to clean out an incision, or for explaining the risks of the various medications, that sort of thing. And sometimes in hindsight, the patient or the caregiver wish they had been more assertive. They might have wanted to ask more questions, and they found that when there was a family member or other caregiver present, it did really make a difference. And patients, as they again reflect, wish they had been more aggressive in asking questions or pushing for details that they needed once they returned home. Also, they found new diagnoses can really pose some special challenges. It might be overwhelming. Again, they might not have gotten the information that they hoped for. They might wanted more one-on-one time with the physician or the clinician, more hands-on training, how to manage more of that follow-up care. And so they kind of were left wanting more, hungry for more information. Their primary care physician might have been missing from the picture, and that happens in a number of cases. And so the patients were leaving the hospital, and maybe that GP appointment was not set up, or maybe they did not make it to that appointment. So again, there was maybe a breakdown in some of that communication. Some had limited or no support at home, especially single or divorced individuals. Many of them were returning home alone, too weak to care for themselves, and they weren't, surrounded by that support system. Some were not ready to change their behaviors. Sometimes it is hard to get someone to change the way that they eat or their habits. And so some of these discharge plans, they weren't really adhering to. And for some of those, it triggered eventually a readmission. And then, there are those that, have chronic conditions, maybe felt, again, that lack of education. And then what was interesting, I think one interesting finding of the report is if their doctor, their primary care physician was affiliated with the hospital system that they were within, they was likely to have better outcomes. But if they weren't affiliated, sometimes there was confusions about that follow-up care and where to go and those kinds of things. So again, I think it's so interesting to get the provider perspective versus the patient perspective. And it can just help us be extra mindful when we are working with the patients, the clients that we see on a day-to-day basis. And so, we've kind of talked about readmissions, what they are, how frequent they're happening, some considerations for older adults. But I mentioned that there are really kind of 5 types of risk factors that really have stood out to me over the years that I wanted to highlight in this presentation today. And so we're going to go through these 5 next. So the first is memory issues. We're going to go back to the topic of falls. We're going to dial a little bit deeper into living alone because we see that commonly associated with readmissions. We're going to talk more about someone that's managing more of those chronic conditions. And then the 5th, we'll dive into medication management. So first is memory issues. We know that having some sort of cognitive impairment, Alzheimer's disease, another type of dementia can increase the risk of readmission. Over 50% of hospitalized individuals living with dementia have a multimorbidity, and they're at an increased risk of hospital readmission 30 days after discharge. And research has found that 20 to 40% of these readmissions for those with memory issues are likely preventable. We also know just generally that hospitalizations for those living with dementia and those without, those that are living with dementia, the hospital costs are generally higher for those individuals. And there's also often more costs associated with their post-discharge needs. And that might be due to the fact that someone living with dementia, they're likely to need more support to carry out that discharge plan to help them transition back home. It really can, depending on the person's kind of mental status, where they are in the disease process, that can really kind of determine how they can or cannot adhere to those discharge plans. So they might have challenges interpreting those plans, putting them into action. And we know as a person progresses through a cognitive disorder, they're more likely to depend on others for things like their activities of daily living and even those independent activities of daily living, just kind of the day-to-day things that happen in a household, like meal preparation, taking their medications, that sort of thing. So we need to be extra mindful of those that have some sort of cognitive impairment as they're transitioning home from the hospital, to make sure that we're setting them up for success, making sure that they have safety supports within their home, making sure that their medication list is up to date, because we really want to reduce the risk for things like falls and any other accidents that can happen in the home. So speaking of falls, that was the next one that I wanted to hit on. We know that falls, they can be the cause of that initial hospitalization, but they also can be the cause of a readmission. So we have to kind of watch out for it on both sides of the coin there. And we also know that once a person falls, they have twice the chance of falling again. So their chance doubles that they'll fall again in the future. And so we need to be mindful of those that have a history of falls. Again, cognitive impairment is closely linked to a person's fall risk. We also need to recognize, if they've had long spans of inactivity in the hospital, they might be weaker. So they might need to use an assistive device, or we might need to install grab bars in the home so that they can safely get on and off the toilet or in and out of the shower, that sort of thing. We also know that those that are isolated are at a higher risk. We know clutter within the home, those pesky rugs and other tripping hazards can put them at risk. Lighting is another thing we need to be aware of. Is there proper lighting? I was in an older adult home recently, and it was the middle of the day and all the lights were off. And that person was trying to navigate the stairs to the basement. And I I quickly turned on as many lights as I could because I could tell that this individual was having issues seeing the stairs. And so sometimes older adults want to save a few dollars on their electrical bill by keeping the lights off and think that the natural light is sufficient within the home. But not having that proper lighting can be a potential hazard. Also, people don't always associate hearing and vision issues with falls. I mean, vision, that seems pretty obvious. If you can't see where you're going, you might be more likely to be at risk of falling. But also hearing, if you can't hear your surroundings or a pet approaching, that can, be hazardous, of course. You could trip over that animal. Also, there's a link between kind of balance and hearing. And so if a person has issues with hearing, they might also have some balance issues. And then also if you notice the individual having a change in their gait, their walking speed, or they're shuffling a little bit more, of course we want to pay attention to that. So these types of things can put an older adult at a higher risk. So we need to make sure that we're securing creating a safe environment for them to navigate, making sure that they have the right tools and resources to move safely about their home so we can reduce the risk of falls. All right, so the next one was living alone. We know that living alone is a risk factor for readmissions. A person might not adhere to their discharge plan due to a lack of support or lack of motivation for important elements of that discharge plan that are really important for their recovery, such as maybe their nutritional intake. We know that people that eat alone are less likely to eat nutritious foods. So when you think about it, if a person is lacking that support system, they might also be more likely to be feeling lonely. Again, we might see more of those frequent flyers to the hospital for those that live alone. They might be going to socialize. And of course, we want those individuals to have that social interaction, but going back to the hospital might not be the appropriate outlet for that. So can we provide them with social interaction? Can we make sure that someone's checking in on them regularly to help identify any red flags that could potentially cause a readmission? We also know that for those living alone, those that lack social relationships, it's really closely associated with a number of health outcomes. It can increase a person's risk for illness, functional decline, again, that poor nutrition, and even a higher chance of death. So we need to be, again, mindful of those that are transitioning home that live alone. Again, do they have the supports that they need in place? And those, number 4, those managing multiple chronic conditions, we know that they also have a higher chance of readmissions. Often there's an increased level of care coordination needed for these individuals because they might have several healthcare providers or clinicians. So we need to make sure that we have, up-to-date a list of all of their providers, all of their medications, and they might require more care and assistance post-discharge to really help manage those chronic conditions. And on the screen here, we have a list of many of the chronic conditions that could increase a person's risk of readmission: COPD, kidney failure, diabetes, hypertension, cardiovascular disease, even depression. So there's a number of chronic conditions that we need to be aware of. And if you're working with a patient or client that has any of those conditions, we just need to, again, make sure that the individual understands the discharge plan has the supports in place. And then finally is that multiple medication risk factor. There's a systematic review by Morabet and colleagues that reported that 21% of readmissions were likely medication related, and about 69% of those were potentially preventable. But research also acknowledges it can be challenging to kind of pin down medication as a cause of readmission. But we do know the more meds a person takes, the higher the odds of their readmission. One study actually found that um, 10 medications or more puts a person at higher risk. And also, the chance of readmission increases for every additional medication provided. And so, again, often we want to make, we can underestimate perhaps the impact that medication can have on a person as they recover. So we want to make sure that they are taking the proper medications, that they did get their prescriptions filled, and that they are taking them appropriately. And often there is maybe a new medication that's introduced after a hospital discharge. So working with the pharmacist to make sure that there's no adverse drug interactions, that's really important. Or if you notice any new symptoms, especially things like dizziness or weakness or lack of appetite, any of those new symptoms after starting a new medication, after a discharge from the hospital, we want to make sure that we're getting those addressed, reporting those back to the healthcare provider so that it doesn't eventually cause a readmission. And medication adherence is a challenge for some. We know 50% don't take their medications as prescribed. More than 1 in 5 new prescriptions actually go unfilled, and 50% of patients discontinue a medication within the first year. They might start to feel better and therefore stop the medication, but for some, they're feeling better because of the medication. And so if they stop, they might be causing more harm to their health than they realize. So it is important to do a med reconciliation, make sure that the general practitioner or the regular clinician that they see knows about the new medications so that we can be checking to ensure that there's no adverse reactions. And also I wanted to call out opioids. Sometimes for pain purposes, they are prescribed, but opioids can increase a risk for falls. And there's a lot of other risks involved, like abuse of opioids and whatnot. But opioids can impact older adults differently than younger cohorts. So we want to make sure that if there is an opioid introduced, again, that we're taking into account what are the other medications, have we talked to a pharmacist about this, and how long does the person need to take that medication. And let's have a heightened awareness of the person's risk for falls, because we know that those two, taking an opioid and falls, are highly correlated. So when we are getting ready to discharge from a hospital or a rehab facility, we want to encourage patients and families to be proactive to prevent readmissions. And this is where, again, a lot of hospital and healthcare systems are doing a lot of great things to help set families and patients up for success. But there's 3 things we really want to make sure are happening. And sometimes it's the little things that tend to get overlooked when a person discharges from the hospital or rehab facility. And so some of these might seem obvious, but when you are stressed and you're dealing with a lot, you're trying to figure out how are we going to get mom or dad or my spouse home from the hospital, you might overlook some of these things. So if we can provide the patients and families that we work with resources to give them things like little checklists or little tips, that can really go a long way in helping families kind of process all the things that need to be done and make a plan. So we're going to talk about assembling the care team, preparing the home, and then being vigilant and monitoring for signs. So first, when we think about the care team, it's really important to have a team in place, if possible, to prevent readmissions. And so when we think about support in the home, we need to ask a few questions. How long is support going to be needed? Is it for a few days, a few weeks? Or has this person declined to a point where it's probably going to be needed indefinitely? It's also important to determine, when is the care most important? Like what time of day? Is it during the day? Is it during the evening, overnights? And when working with a patient or a client, I know for us at Home Instead, often when we come alongside a family after after discharge, a person might need around the clock care. And maybe it's a combination of home care and family for the first few days, 24 hours a day. But as the person starts to regain their strength, starts to recover, that schedule can then be modified and they can kind of wean off on the support needed over time. So I think that's an important thing to determine. Again, what is the care situation that is needed and what is the extent, because it might be easier to have that, or to when you realize that you might not need that 24-hour support ongoing, it might just be for a few days or weeks, and then you can taper off. It's also important to determine, who in the family, if anyone, is able to provide support. Again, they might not be available due to distance. They might live out of state or in another city. They might also be working, and so they might not be able to help. Or perhaps if it's a spouse, they might have their own health issues that they're dealing with. Or if it's an adult child, they might have their own family obligations and might not have the capacity to support. So really important to determine if family is available and how much help they're able to provide. And then looking into professional support services, the two most common that are recommended when returning home is home health and home care. And there is a difference between those two types of care, and I'm going to dive into that in just a little bit. Home health care is often a service that's paid for by Medicare when a patient returns home. There is some specific criteria needed, and it's also usually a short-term service. Home care is another means of support. It's not covered by Medicare. It's primarily self-pay or sometimes covered by long-term care insurance. But home care has more kind of flexibility in terms of the number of hours and the time of day and for the length that it's needed. And then consider other supports as well. Things like a Meals on Wheels program. If a person maybe lives alone, they might not have the energy or the strength to cook for themselves. Having a daily nutritional meal delivered can be a game changer for some. And so tapping into those other types of resources can be helpful. Or perhaps there's a volunteer program in the community that can come and, be with the individual to give the family a little break or respite. But let's talk a little bit more about family support, because we're finding that when caregivers or care partners, family members are integrated into the discharge planning, it really is helping to reduce the risks of readmissions. And so, again, there's a lot of communication that's involved with discharge planning. And so if there can be a primary caregiver or family member involved in the process as often as possible, there can be some benefits. So a study has found that there's a 25% reduction in the patient being readmitted to the hospital within 90 days and a 24% reduction in being readmitted within that 180-day window when there were caregivers integrated into the discharge plan. So I know a lot of hospital systems are starting to ask, do you have a caregiver, making sure that that person is documented, and then involving them in the care coordination. And I know that there are potential issues with things like HIPAA, healthcare powers of attorney, those kinds of things that might come into play in these types of situations. But if we're able, again, to involve family, there's likely to be better outcomes for the patient. And then when we think about some of the key roles for families, there's often some kind of primary roles that are very closely related to the discharge planning process itself. And then there's some secondary kind of roles that they are likely to play as it relates to kind of discharge planning and hospitalization. So, family can be very key in helping to understand those discharge plans and the goals of the patient. They're able to often help prepare the home for returning to the home, that communication between family members and the patient and the care team, providing instructions and training to other people involved in the care situation. And often they can help prepare and maintain those medical contact lists, those emergency contact lists. And then also some other things that tend to crop up around hospitalizations that families a lot of times help with is things like paying medical bills, helping to assist with kind of mail and other tasks around the house once they return home, and then also helping with some of those important documents I just mentioned, making sure that things like advance directives, living wills are all up to date and accounted for. And then, like we talked about, beyond family, if family is unavailable or they have limited availability, it can be helpful to have those professional services come into the home to help with that individual post-discharge. And the first is home health care. And I mentioned that home health and home care are two separate types of services. Home health care focuses mainly on medically necessary care for rehabilitation and education to the patient and families to help make progress towards the goals of the patient. This type of care is often ordered by the doctor, might include a nurse, physical or occupational therapy, even speech therapy. There might be a home health aide, a medical social worker that are involved in the care. And home health care providers are usually Medicare certified. They will come in for usually a short period of time or for intermittent care. Home health is not going to be there 24/7 to assist. Usually their visits are 30 minutes to an hour, maybe once a day, maybe just once or twice a week. And so it is important to understand how that differs from home care so that patients and families have realistic expectations. So sometimes seeing it in a visual layout like this can be helpful to kind of provide an overview of what services are involved, how is it paid for. And as you can see, it does differ from home care. Home care focuses on support for cognitive, behavioral, functional, and social factors. And so this type of care is provided by home care professionals, aides that are trained to provide care. This type of care can reinforce the discharge plan, that plan of care, and can cover that care and support a lot longer in duration than home health care. For home care services, it can be a few hours a day, up to 24/7. It can be just overnight. It can be, like I mentioned earlier, starting out 24/7 care and modifying the schedule as a person starts to regain their strength and gets back to maybe their old self or reaching those goals. Some people describe home care as kind of an extension of the family. There are extra eyes and ears in the home. And often it is an agency that employs home care professionals. And often they train them on the specialized care that's needed for older adults, especially when it comes to things like Alzheimer's and dementia care. So if somebody's living with cognitive impairment, home care can often be a good support. And if you are kind of vetting a provider, you want to ask, what is the training involved and how can they support an individual living with cognitive impairment? Again, on the slide, it kind of is a nice layout to describe the types of care provided by home care, anything from medication reminders to providing for those nutrition and hydration needs. They can provide transportation to those follow-up appointments and support those living with cognitive impairment. Payment looks different for home care than it does home health care generally. It's often private pay or family funded. Again, some long-term care insurance can cover it. If the person is a veteran, there might be some veterans assistance. And then Medicare Advantage plans will sometimes cover home care services. And then if a person does qualify for Medicaid, there might be a Medicaid waiver that could cover potentially home care. So beyond the people and the supports in the home, we want to make sure that the home itself is set up for success. So For an individual that's been hospitalized, they may have been away from home for a number of days. If they went to a rehab facility and they're discharging from rehab, they might have been gone for several weeks. So when you're coming home, you want to be sure that the home is set up for success. Make sure any of the medical equipment is put into place, make sure those prescriptions are filled. You've had a conversation about medications with the pharmacist, if possible. Any safety improvements like adding grab bars or removing those throw rugs to make sure the pathways are clear. That's really important. Arranging for rides for those follow-up medical appointments. Maybe it's a combination of family taking them to those appointments or home care coming in to get them ready for the appointment, transporting them there, meeting that family member at the appointment so that the family member can sit in on the follow-up appointment but doesn't have to take extra time out of their workday to get their loved one ready for the appointment and transport them there and back. And also, again, little things that you might not think about, making sure that there's healthy food in the fridge and that you've cleared out any spoiled or rotten food that has been left in there for a couple weeks, especially if they've been gone extended period of time. Also, things like changing the linens, making sure there are clean sheets. Again, little things, but they can go a long way in making sure the person returns to a comfortable and safe home environment. Then the last part of this is to be vigilant. You want to pay attention to warning signs in the first few days and the first 30 days. Often it's those first days and hours back at home when it can be very critical to be vigilant, making sure that that they're taking their medications, that they're eating meals, that they're getting the assistance that they need, they're getting up safely to use the restroom or getting up safely in the morning from bed to reduce the risk of potential readmissions. And then, as you look out to those 30 days, making sure they're getting to those doctor's appointments, that they continue to take those medications, and then they get extra help if they need it. Those are really, really important things to be paying attention to, in addition to warning signs. And there are warning signs where a person should call their doctor versus calling 911. And so there are some suggestions there on the slide. Situations when you might want to call the doctor, things like no bowel movements in 3 days, or if there's a new skin problem, maybe you're noticing some changes in their balance, coordination, or strength. Maybe you're noticing kind of their mental status or behavior has changed. Sometimes a urinary tract infection after a hospital stay or really any time can some of the symptoms of that can be confusion, disorientation. It can kind of mimic some signs of cognitive impairment. And so we want to make sure we're calling the doctor to get them in to be seen. If they're having medication issues, if they're having more dizziness, make sure you're calling the doctor. And then there's situations where you need to call 911. You do need to get to the hospital right away. If they have a fall and they're bleeding or have a broken bone, if they've had prolonged bleeding or severe pain that's ongoing, if you're unable to wake the individual, if they have a new onset of slurred speech, it could be due to something very serious like a stroke, or if they have sudden weakness or chest pain that is occurring, or difficulty breathing. Those are situations, of course, you want to call 911. So again, educating families on these things to keep an eye out for. Sometimes a family member might think, oh, I need to call 911 for this, when really they could call the doctor, get in to see the doctor the next day. It might not be as urgent. So by educating families on the types of warning signs, it can be helpful. So I wanted to leave you all with some resources. Home Instead puts out a number of guides that are free, downloadable, to help families and patients navigate some of these challenging situations or prepare ahead of time for hospitalization. So this guide in particular, 5 ways to prevent hospitalizations has some great kind of do's and don'ts, goes into more detail on those warning signs that I just talked about, and then some ideas, resources, and strategies on, again, how to prevent hospitalizations. And if you download the slides, which I know you can do within this webinar platform, if you click that pink words download guide, it hyperlinks to where you can download your free version of that. We also have a returning home guide, some great questions in there to ask before leaving the hospital, some checklists, and then some of those kind of back at home, what things should I be looking for, tips are in there. So again, if you click download guide on the PDF version of these slides, it'll take you right to it. Or if you just go to homeinstead.com and search returning home guide, it should pop up for you. Some more resources. I know I'm throwing a lot your way, but I want to make sure you have a lot of great resources to pass along to families. Everyone, I think, appreciates free, helpful resources. One that I find to be so helpful for families when explaining the difference between home health and home care is our home care solutions guide. Again, you can download it for free, but it talks about, okay, what is the difference? The services that are covered in both, kind of like the slides I went over today, but also includes important questions to ask when you're interviewing those organizations to come in and provide care for you as the patient or your loved one. Also, when it comes to home safety, we have a home safety checklist, and it walks you through every room of the home and some things to consider in terms of safety, but also some suggestions for things to help increase the safety in those environments. And then also an action plan for successful aging. This plan is kind of more long-term, but sometimes we find that a hospitalization can kind of be a wake-up call for a patient or a family, and it gets them to start thinking about planning ahead. And hopefully by then it's not too late, but this guide walks through a number of very important areas for planning. Things like finances, health, living situation, and more. So please feel free to go to Home Instead's website, homeinstead.com, to download those guides. And then again, just wanted to highlight for home care services, of course, at Home Instead, we provide those. So we have locations in all 50 states. So you can do a zip code search on our website for where the patient lives to see if there's a home Instead home care provider near you. And then also for those home delivered meal programs, Meals on Wheels of America has a great kind of zip code search there as well to find a program nearest to you. And then of course, our area agencies on aging, such a great resource for a lot of things related to aging. Often they're associated with the Meals on Wheels program, and some can connect you locally with resources. And then some markets have PACE programs for individuals that qualify on an income level for some extra support and resources. So with that, I know we're almost out of time, but we might, Victoria, have an opportunity for one or two questions. So I will just say a quick thanks for listening, and I'm excited to answer some of the questions as they've come in during the presentation.
Yes, we do have a lot of good questions. I'm so sorry we're not going to be able to get to all of them today, but some of them are tied together. So the first question that we have is if you have any suggestions on how we can get hospital discharge planners to coordinate with us. And us, I don't know if that's caregivers or case managers or social workers, but, kind of getting that coordination, because they, discharge planners have a lot going on. Everybody's very busy. But, there are sometimes issues where people are getting discharged without necessarily alerting those case managers or advocates. And then kind of along with that is there any specific training or resources available for healthcare providers to improve discharge planning and follow-up care? So those are, I think, kind of tied in together. That's a lot.
Those are great questions. And I think you're right. Discharge planners, they are busy. They have a really tough job. I think if you are any sort of professional that's working with an older adult and want to be kind of included in the discharge plan. I know when I would have patients, when I was working in our local home instead that I knew were hospitalized, I would make sure to stop by and give them my business card just so that they knew they were working with home instead. And so when it came time to discharge, that to please reach out to me and I could help coordinate the care that was needed. I think often many hospital systems, they have lists of providers to help support older adults, and often they can't make a recommendation because often they're a nonprofit, and so they have to kind of abide by certain guidelines, and that can be very overwhelming for families. So I think at the very least, the guides that I shared that are hyperlinked in the presentation can give families great questions to ask the discharge planner to help. Sometimes you're given a packet of information. It can be hard to sit through that packet in front of the discharge planner and ask questions as you're reading it through. But if you're able to kind of go in with a set of questions ahead of time, and you can ask those questions, hopefully you can get some of the answers and things that you need for your return home. And I think it's also important to ask, if we have questions once we get home, who do we follow up with? I think that's probably one of the most important questions too. Again, there's a lot happening at discharge. It can be chaotic, but making sure you know who you can follow up with, that's really important. When it comes to what can hospital systems do, there are some really great programs out there actually. When it comes to, I am attending a conference actually coming up hopefully, where, and I'm trying to find the email because it had a great organization, and the name of it is escaping me, but they are your hospital system can become geriatrics certified. The name of it, oh gosh, Victoria, hop in if you know what I'm trying, if you know
I don't know, but you know what, we can, if we find it later, I can send something out so
yes,
that you all have this information.
perfect. Oh goodness, I hate that it's escaping me right now. But there's often, there is an organization, Nurses Improving Care for Healthcare System Elders. It's called NICHE, NICHE, NICHE. I finally found it. And so that is one program that you could go seek out to see, can your hospital system engage in that program? There's also a number of age-friendly health systems, and there is this framework called the 4M framework. And so your hospital system can adopt that. And so you can look into it if your hospital system hasn't already developed a program such as that. But those are kind of the things that we're seeing come about to help really cater to the older population, because sometimes they just have a little more complex health situations. And so if we can train the healthcare workforce to kind of better work with those individuals and their families and their caregivers, then hopefully we'll have better outcomes for all. So thank you for those great questions.
Thank you. If I can just ask one more question.
Yes, please.
I know we're over time, but I see that y'all are still on, so I know you're invested. These two are also kind of tied together. Do you think older adults are good candidates for remote patient monitoring programs, given the risks that you've reviewed? And then it also ties into a question of how do you see the role of technology in addressing the needs of patients and caregivers in home health and home care?
Ooh, those are really good questions. I think that there's great opportunity. I think what's so great about working with older adults is everyone is so different. Their situation is different. So there might be certain conditions that don't lend as well to remote monitoring and technology as others. I think that I'd be hesitant to say that it could replace an in-person visit, because there's so much that you can get out of an in-person visit, but I think that it can supplement in-person visits, especially when it comes to monitoring someone's health status after a hospital or rehab discharge. So I think that there is opportunity. I think that and there are some people or some systems out there that are doing that. And then I think that kind of from a home health and home care perspective, there is opportunity there as well. I think sometimes in home care, technology, again, never can replace the human touch, but there are ways we can utilize it to create some more efficiencies in the work that we do. So I think that, there's more to come on the topic of technology as it relates to readmissions and providing better healthcare for older adults.
Thank you so much. Thank you all for participating today, and a special thanks to Home Instead for bringing us this webinar. Thank you for hanging on with these extra questions at the end. They were just so good. Please do review our FAQs page. It's linked in the announcements right below. And then you can also access it within your classroom on that left panel if you need to. The presentation, the slides for today are available in the materials tab right above the presentation slide. You'll see a tab that says materials. You can access the presentation slides there. You can also go back to your classroom and access it again. The application for certificates for CEs and certificate of attendance is in the certificate application tab right at the top of the presentation slide as well. Please be sure to select a certificate type. So it's going to be labeled credit reporting organization, but that is your certificate type. If you don't make a selection, we won't know what kind of certificate to generate for you. So you have to make a selection and enter your license number if it's applicable, and that's going to be labeled as your membership number. So please don't get thrown off by that. Make sure you make those selections so that we can ensure that you actually get your certificates, and you can download it as soon as you complete the application, which is available to you right now. And you can also go back to your classroom and just click under My Certificates if you need to access it again. Again, thank you all for joining us today. Make sure you check out our upcoming webinars, including addressing challenging family dynamics in caregiving, which is going to be coming up on August 7th. And thank you again, Lakeland, and everyone here today. We appreciate you. Have a great one.